Hi everyone. Today we will be talking about the treatment of atopic dermatitis, and I'll be concentrating on phototherapy, immunosuppressives, and the use of biologics. So why do we want to consider phototherapy for treatment of atopic dermatitis in children? Safety is always a major concern when we treat children, especially children who have atopic dermatitis that is severe and chronic. And the use of systemic agents have associated systemic risks, for example, opportunistic infections as well as cancers. In children who have suboptimal control with topical treatments, phototherapy may be a good choice. And you can consider phototherapy also in children whose parents are steroid phobic. How does phototherapy work? There are two types of light that we use in phototherapy. One is ultraviolet B or UVB. This can be given either as narrowband ultraviolet B or broadband ultraviolet B. Ultraviolet B usually penetrates only up to the epidermis and leads to depletion and functional modulation of Langerhans cells. It also suppresses the production of ICAM1 from the epidermal keratinocytes, leading to an increase in IL-10, which is immunosuppressive. UVA or ultraviolet A penetrates deeper into the skin and goes into the dermis. It leads to depletion of Langerhans cells as well as depletion of dermodendritic cells. There's suppression of ICAM1 as well, leading to a production of interleukin 10, which leads then to a reduction in interferon gamma as well as T helper cells. There's also a decrease in IL-1, IL-6 as well as collagenase. So the types of phototherapy that we use for atopic dermatitis include narrowband ultraviolet B phototherapy. Some centers also do combine UVA with UVB phototherapy, and if it's atopic dermatitis or eczema on the hands and feet, you can try doing soak PUFA. So this is our experience with phototherapy in Singapore. We did a retrospective study and published it in 2014. This looked at the use of phototherapy to treat patients from 2004 to 2008. We treated 25 patients less than 16 years of age with a duration of disease ranging from 2 to 14 years. Most patients have extensive disease of more than 70% body surface area. So 15 patients underwent narrowband ultraviolet B treatment, and about 66% showed improvement. The mean duration was for 11 months after 60 treatment sessions. 9 patients underwent ultraviolet A with narrowband ultraviolet B, and about 55% showed improvement. Treatment duration was about 3 to 4 months, and a total of 22 treatments. So as you can see, probably about 50 to 60% of patients will respond to phototherapy. This is a picture of a patient who had quite extensive eczema that has undergone narrowband ultraviolet B, and this is after about 4 to 6 months of treatment. You can see marked improvement in the eczema. This patient had a lot of prurigo nodules. So generally, in patients who have very thick lesions, like in prurigo nodules, we use ultraviolet A with narrowband ultraviolet B, and you can see after about 4 to 6 months, there's marked improvement in the thickened prurigo nodules. Some practical tips for phototherapy in children. You have to counsel parents and the child, and of course to get consent. We talk about the safety, adverse effects, benefits, and risks of phototherapy. It's important to have some commitment in terms of time, and generally we work around the school or tuition schedules, as well as the parents' own work schedules. For the younger patients, sometimes we allow parents to stand in the unit with the child for the first couple of sessions just to get them familiarized. However, subsequently, parents will have to stand outside the phototherapy room, outside the phototherapy unit, but in the phototherapy room to accompany the child. So generally, we will use goggles to cover the eyes, as well as to cover the genital area. If we're not shining the face, we will also cover the child with the hood as such. However, if we are going to shine the face, we will ask the child to use goggles instead. Then they stand in the phototherapy booth. We make sure that they hold on to a handle in there. For the younger child, we ask them to stand on a step box or step stool, and this is because 10 centimeters on either side of the fluorescent lamp, there is ineffective irradiation. So it's important to check with your vendor on the ideal height of the step box or stool. For the dosimetry for narrowband ultraviolet B, in children it is to do a MED or minimal erythema dose, or MPD or minimal phototoxic dose, and this may not be practical, so we generally use a standardized starting dose, and this is the starting dose that we use at KK Hospital in Singapore. Dose increment each time the child comes back, and we also have a guide for the maximum dose. And as you can see, the dosage will depend on the skin phototype. In Asians, generally, their skin phototypes will range from type 3 to type 6, and these are the corresponding starting doses. For older children, you can start at a higher dose. As you can see in this chart, we start from 300 to 800 millijoules per centimeter squared, depending on the skin phototype. The maximal doses are also higher, between 4 to 6,000. However, most times, once the child is able to hit about 1,005 to 2,000 millijoules per centimeter squared, it is quite adequate. This is the dosimetry that we use for ultraviolet A and narrowband ultraviolet B treatment. Generally, the doses are lower for both ultraviolet A and narrowband ultraviolet B. Again, you will start according to the specific skin type, and we have the dose increments as illustrated here, as well as the maximum doses. Each time the child comes back, we will assess the level of erythema after the last session, and from that, we will then decide how much to increase. So for example, if there is no erythema, we will increase by about 20% of MED or 100 millijoules. If there is some erythema that lasts for less than 2 days, a little bit of erythema when he comes back, and it's a faint pink erythema at the time of visit, we will increase by 10 or 5% of MED, or 50 millijoules or 25 millijoules, and accordingly. If the child misses a treatment for 3 to 7 days, we keep the same dosage. If the child misses the treatment for 1 to 2 weeks, we will decrease by 25%. If the child misses for 2 to 3 weeks, we will decrease by 50%. And if the child misses for more than 3 weeks, we will start from the beginning. In terms of duration of treatment, it may take 6 to 8 weeks to see improvement, and generally we want to see the dosage reach at least 1,000 millijoules per centimeter squared. If the eczema is more severe, sometimes we do add on a tailing course of prednisolone for 2 to 3 weeks, because phototherapy does take about 2 months to work. Generally, we inform patients that they need at least 5 to 6 therapy, sometimes up to a year or even more. I generally reduce the frequency rather than stop treatment abruptly. So from twice a week, we can reduce to once a week, and even once every 2 weeks. Side effect profile of phototherapy, it is quite safe, but sometimes we do see erythema, increased pruritus, pain. Generally, most patients will complain of increased dryness of the skin, so we inform them to use more moisturizers. If the dosage is high, sometimes they can get a sunburn, and that can lead to increased pigmentation. We have seen a couple of patients that have reactivation of herpes simplex infection, and in these patients, if they want to continue on phototherapy, sometimes we start them on a prophylactic dose of acyclovir. If phototherapy goes on for many, many years, there is a theoretical increased risk of skin cancer as well as skin aging. So generally, once the eczema gets better, we ask patients to go on a holiday from the phototherapy. Of course, after a few years, if the eczema returns, then we will restart phototherapy again. Next, I'll talk about systemic immunomodulators for atopic dermatitis, and the 4 medications that we usually use are cyclosporin, azathioprine, methotrexate, and mycophenolate mofetil. It is important to consider the indications of when to start systemic immunomodulators in children with atopic dermatitis. And generally, we use it for patients who have poor or suboptimal response to topicals, wet wraps, phototherapy, and especially if their quality of life is severely affected. Some patients may have contraindications or side effects to topicals or phototherapy, and that can lead to a decision to start on systemic immunomodulators. Patients must be able to undergo regular blood draw for monitoring, as side effects, we have to monitor for side effects. And it's important that patients and parents understand and accept these possible side effects. Some exclusion criteria include known allergy to specific immunomodulators, patients who have previous cancers, and patients with current chronic infections such as tuberculosis. We generally try to hold off the use of systemic immunomodulators until the child is a little bit older, sometimes even starting only in teenage years. We want to try to use the lowest dose possible to maintain a good quality of life. We generally do some baseline monitoring, including full blood count, liver function tests, and renal panel. We also do infective screens in older children, or if the patient comes from endemic areas, and we test for hepatitis B and C, HIV, as well as tuberculosis. With regards to each immunomodulator, for cyclosporin, we find that it works the fastest, and we can see results within 1 to 3 weeks. We give at a dose of between 3 to 5 milligrams per kilogram per day in 2 divided doses, and we monitor the blood pressure, renal function, as well as lipids, and generally we try to tail off by 1 year. Methotrexate has a slower onset and may take 2 to 3 months. The dose is generally up to 0.5 milligrams per kilogram per week, and we monitor the full blood count and liver function tests. Methotrexate can be given for a few years, and some centers perform a fibroscan or liver biopsy after reaching a total cumulative dose of 2 to 3 grams per kilogram. Azathioprine has a slower onset and may take 2 to 3 months to work. Doses range from 1 to 3 milligrams per kilogram per day, and we monitor the full blood count and liver function tests. Patients may be given azathioprine for a few years. Mycophenolate mofetil also has a slow onset and may take 1 to 2 months. Doses range from 20 to 50 milligrams per kilogram per day in 2 divided doses. We monitor the full blood count and liver function tests, and again, MMF can be given for a few years. I would like to refer you to this paper, Non-Topical Management of Recalcitrant Pediatric Atopic Dermatitis, found in the Archives of Disease Child, if you want a more in-depth discussion on the use of systemic immunomodulators for atopic dermatitis. This table is found in that paper, and it will guide you on what to screen for and the doses for the treatment for the use of systemic immunomodulators in atopic dermatitis. Finally, I'd like to touch on biologics for atopic dermatitis. And we do know that the Th2 pathway is increased in atopic dermatitis, and this produces increased interleukin 4, interleukin 5, and interleukin 13. We now have Th2 antagonists, and the first one that we are using now is dupilumab. This is a human monoclonal antibody that targets the common IL-4 receptor and blocks both IL-4 and IL-13 signaling, and inhibits the entire Th2 pathway. Has been shown to have good efficacy and is well tolerated with very transient side effects. Another Th2 antagonists are tralokinumab and lebrikizumab. These are specific IL-13 antagonists, and both are in clinical trials for atopic dermatitis. And why this works is because IL-13 is found to be responsible for many of the pathogenic Th2 side effects in atopic dermatitis. So both drugs will be useful for the treatment of atopic dermatitis. Another cytokine that has been found to be increased in atopic dermatitis patients is interleukin 31, and this is produced by Th2 cells and primarily causes itch. So nemolizumab is a IL-31 antagonist, and is shown to reduce IL-31 and induce scratching in animal models, and currently is undergoing clinical trials for the treatment of atopic dermatitis. JAK-STAT signaling has also been found to be activated in atopic dermatitis. And now we have JAK inhibitors that have potent anti-inflammatory, anti-proliferative effects and inhibit cytokines such as interleukin 4 and interleukin 9, 7, 15, and 21. Trials for JAK inhibitors are ongoing. So in conclusion, Phototherapy and systemic immunomodulators may be considered as second-line treatments for moderate to severe atopic dermatitis, especially if the patient's quality of life is affected. It is important to monitor for side effects, which may be short-term or even long-term. Biologics are new medications which may be considered if second-line agents are contraindicated or have poor treatment results. And with that, I want to thank you for your kind attention.